There's a relatively new standards reporting system that we now use, which helps particularly with regards to the extent in terms of anatomic definition of the dissection. Along with this, the nomenclature has changed a little bit, so we now have hyperacute, acute, subacute, and chronic, and I think sort of the acute, subacute is where we're going to land in terms of how we treat these patients. And then in terms of symptomatology, there's complicated, uncomplicated, but now we have this newer category of high risk as well. And treatment has been optimal medical therapy, open repair, and then TEVAR. In terms of complicated type B dissection, we think of rupture and we think of malperfusion, and malperfusion can be neurologic, visceral, lower extremity, as you see here. High risk, again, a little bit new, so I think the two things that we always thought were high risk but weren't defined are pain and hypertension that are refractory to initial optimal medical therapy, large initial aortic diameter, large false lumen diameter, a few other things here, radiographic only malperfusion, bloody pleural effusion, and then entry care and cluster. So refractory pain and hypertension, this is pretty old data, but if you look, this patient population is significantly higher in hospital mortality, and I think it's something that's pushing us to intervene in these patients sooner than we had in the past. As I mentioned, treatment options, medical therapy really based on anti-impulse therapy. TEVAR has really become the standard of care for all complicated type B dissection since it was first initiated in 2005. Really an expanding role for these high risk and uncomplicated patients. And then open repair is becoming more and more rare, especially with the newer devices. In terms of goals of TEVAR, what we're trying to do here is prevent and treat the rupture and alleviate malperfusion. Just with surgical techniques, we're trying to seal off the entry tear, expand the compressed true lumen, and induce false lumen thrombosis. And long-term, trying to prevent anginal degeneration, not only of the thoracic segment, but also the abdominal segment. In terms of planning, as I think we've seen in all these talks prior, really CTA is the gold standard, what we use in terms of planning, and as you mentioned, using centerline and so forth. Really, when you're thinking about the anatomy, you want to know the start, the extent, and the end of the dissection, what your landing zones are going to be, identifying the true lumen, perfusion of where the branches are coming off the true and or the false lumen, and then as with TEVAR for aneurysm, thinking of vessel size in terms of access with regards to their quality, tortuosity, and so forth. So ensuring the true lumen, obviously, is sort of the key to this operation, and really, once you go into this procedure, you should know this really based on the CT scan in terms of where the wires are going to end up. False lumen tends to be concentric in shape, true lumen tends to be round and more compressed. And then for us, certainly EVSS is used in any and all of these cases, and then it sort of defaults coming from the right arm if there's an issue trying to get into the true lumen. Like I mentioned, EVSS we use in every case. It's really an adjunct to all these other imaging studies. It helps assure you're in the true lumen. You can size the angiograph after the fact and assess the adequacy of treatment and guide whether you need to treat any viscerals, especially in the malperfusion cases. Proximal landing zone really needs to be non-dissected aorta. Left subclavian coverage is needed in 30 to 40% of patients, either with, and we try to revascularize when possible, either with bypass or transposition. As you've seen before, we now have another device now available to us commercially in the U.S., which is the GOR-TPE device. And this has really changed sort of management of patients where, previously it required a sternotomy. Here's a zone 0 TEVAR with the total artery branching, all done very conveniently. In terms of accurate deployment, so we always think of sort of the last move back over the wire. As you heard, just in the infrarenal devices, we can pull these things back, but not push them forward as easily. So you always want to make sure that the stored energy is gone from the graft. Really having someone push forward pressure on the wire to get the most apposition against the outer curve and minimize distal migration. Back previously we used a lot of these adjunctive measures, sort of decreasing the pressure, added adenosine, rapid ventricular pacing. It's very rare we end up using these anymore. Most of the new devices don't require such techniques, but good to know and to have. In terms of length of coverage, it's always a balance between trying to get aortic remodeling versus the risk of paraplegia. We typically cover from the subclavian down to the diaphragm. That being said, try to spare some of the intercostals at the T8 to T12 level with regards to concerns with paraplegia. And obviously, we're a little less aggressive when the subclavian's been covered without revascularization. Certainly don'ts, we don't want to oversize, nothing more than 10%, avoid any sort of angioplasty, always avoid placing the distal device first, and then landing in dissected aorta proximate. What we're trying to do here with all these techniques is avoid retrograde dissection. In terms of malperfusion, there's dynamic and static. I won't try to spend time on this. Dynamic, typically alleviated with the placement of a T-bar. Static, more often, as you've seen from others, requires selective angiography and adjunctive stenting into the true lumen. Just an example of IVUS utilized to cross over and treat a right renal. So just quickly, timing really is everything. This is meant to be a very narrow window. That's the little picture there. So in the acute phase, the aorta is inflamed and fragile, so you need to be careful. But and we know that early repair is associated with major morbidity, including and worstly retrograde dissection. However, if treatment's left too long, we know that these patients require multiple interventions. There's a lot of mixed data in terms of this. A lot of the early studies were done, and if you look, the patients that were treated early had high rates of morbidity. But if you parse out the data in all these early trials, you know that the majority of these patients that were treated early had symptoms that couldn't be left to wait. That is being frank rupture, contained rupture, and malperfusion. And this is just looking, again, when you look at those early patients, very high rates of complications. Similarly, this is data from the Medtronic Valiant trial, and parsed out a little bit longer, looking at 15 days, subacute and chronic. Same story here. Sort of that sweet spot, the subacute patients where the risk of retrograde dissection is lowest, mortality is lowest as well, and then freedom from secondary procedures falls somewhere between. As you'd expect, in the patients that you treat more acutely, you're going to expect more false limb thrombosis. Again, perhaps a reason to treat these uncomplicated patients sooner than later. A bit more data. This is the great registry looking at the Gore device, and then really specifically looking at, again, these are all uncomplicated patients. And if you look at those patients that were treated in less than 3-day period, had a significantly higher rate of aortic-related complications, meaning twofold. And the sweet spot here was waiting 11 days or more. One last bit of data, this is VQI data, and looking at subacute versus chronic in the 1 to 14 day patients versus 50 to 90. This is, again, all uncomplicated patients. And if you look, no difference in mortality, and this kind of goes against things that we didn't believe, but actually in terms of reinterventions, the patients that were treated early went on to have more reinterventions. Hard to sort of figure out that's a sicker patient population, maybe some of these did go on to have malperfusion, a bit unclear. That being said, in terms of timing, complicated patients need to be treated within 24 hours. When we think of the high risk acute type Bs, as I mentioned before, uncontrolled pain and hypertension, ideally waiting at least 24, and certainly looking at the data trying to wait 72 hours or more, but treating them in a less than 2-week period. In those that don't have those high-risk features, meaning just a large diameter or large false lumen, we try to wait at least 2 weeks, and certainly less than 90 days. In conclusion, there's certainly been a paradigm shift in the last decade with the application of TVAR as the treatment of choice for complicated type B dissection. Certainly an expanding role for TVAR in patients with high-risk type B. Preoperative planning with regards to using CTA in combination with intraoperative vascular ultrasound at the time leads to the most optimal outcomes. And then, as you said, I saw the data is a bit unclear, but I think clinical implication more than exact timing may lead to using TVAR in the most optimal setting. Thank you again for the invitation.
So, unfortunately, Dr. Kobala was in